So, good afternoon to all of you, and I thank KSOS for this opportunity. Sir has talked about what is there in studies as well as real life scenarios. Now, in diabetic retinopathy, our real life scenario is not very good. We have tried our best in most of these things. We do laser, but everything is inadequate. Maybe the treatment is inadequate. Maybe the working mechanism, as Sir said, after 2-3 injections, the effect goes. So, what are we trying to do, and why is it important? So we are trying to prevent severe vision loss. So the first thing that you should know is what is severe vision loss. It is easy to say it is 5/200 less than. What do you mean by 5/200? That is at a distance of 1.56 meters, you are not able to see the top letter. So just seeing that top letter there at 1.56 meters on 2 consecutive 4-month period. That is your ETDRS, this thing. So what is the treatment? Treatment is you have to get treatment as soon as possible for diabetic retinopathy to prevent severe visual loss. That is the only thing. Now, what is the cause? It is one of the leading causes. It is a pandemic now. So this sight-threatening diabetic retinopathy is the part which we have to start recognizing. So this is the severe NPDR stage, the PDR stage, and the diabetic maculopathy, which if left untreated will go into severe blindness. So the prevalence is 1/3 of diabetes have diabetic retinopathy. Out of this, sight-threatening diabetes is 10.2%. That is 28 million people with diabetes have STDR. That is not the only thing. They are all coming up. Further and further, you are going to have a very large population who are going to go blind if you don't know what to do. So what is the preventive step? Basically, increase awareness and do systematic screening. And now there are personalized retinal screening strategies where it depends upon the age, sex, duration of the disease, the anti-diabetic medication, HbA1c levels, and the life expectancy. So in the rural setting, they have sort of given these charts which are predictive models for the next 3 years what is going to happen to you. So if you are on 2 drugs, or if you are on insulin, if you are a male or a female, they have given percentages which tell you that this is going to be your 3-year risk for developing diabetic retinopathy. So that the patient will also be there aware of it. So the diabetic retinopathy increases significantly for every 5 years of the duration, but if it is after 60 and that patient does not have diabetic retinopathy, or if it is after 20 years of age, then it is less likely that he will get DR. Now the main point is that we have to detect early DR. Now what is that? That means that you have a dot hemorrhage or 1 or 2 microaneurysms. And here you must, once you see this, you must have a close relationship with your primary care physician. And we can do, these are the things, standards which we are doing, that early NPDR can go on to the mild to severe variety, from where it goes on to proliferative. And for these, the mild to severe, till now we are just observing and controlling risk factors. For the PDR, we know that we are doing PRP. It can also progress into the non-center involving maculopathy or the center involving maculopathy. The non-center involving, still it is laser, focal laser, and for the diabetic maculopathy involving the center, it is anti-VEGF. So now our question comes, how do we prevent progression? So we know that we can control the risk factors. Can we do anything better? So there was this oral fenofibrate, which is an anti-lipid lowering agent. It had studies, it did tell us, but because of certain problems, it went off. But it is slowly coming back. So there were 2 major studies, this fenofibrate intervention and event lowering in diabetes, and the ACCORD study. What it told us, basically action is independent of diabetes, the lipid lowering agent. It's not basically an anti-lipid lowering agent that is working. It is something else. It is down-regulating VEGF, it is preventing leakage. So the dosage that we give is 160 to 200 milligram. In field study, they found out that there was a 31% reduction. What they did was they took 10,000 patients who got this drug and 10,000 patients who were just followed up. These people, all of them, both the groups had diabetes. So after a few years, they found that those who took this drug did not have as much the laser requirements as the other. So the first laser was less, and the first vision-threatening DME was less. So that means there is one way of preventing it, may be giving this drug. So the other way is a ACCORD study which they did cardiovascular mortality. In that they found out that strict control of HbA1c also helps. But that is slightly life-threatening because cardiovascular mortality is slightly higher if you do intensive control. So here they found that fenofibrate does help, but it only cases with mild NPDR. And if you have no NPDR or no DME, then it's not beneficial for DME either. Only in mild NPDR you can reduce the progression. So in moderate to severe NPDR, we still don't have anything except control the major risk factors, which has been told to us as anemia, lipids, renal disease, etc. But there are certain periods which you must look for, follow up for pregnancy, puberty, and after cataract surgery. Now, NPDR with DME is what Sir talked about. Ranibizumab is now the first-line therapy for central involving diabetes mellitus. But it has also been approved in FDA, has also approved it for non-center involving. Only thing is, most of us are not giving it for non-center involving yet. The reason is you have to give it monthly treatment. So sometime it is combined ranibizumab and laser treatment which helps. So focal laser photocoagulation has been told to reduce moderate visual loss. Moderate visual loss is 20/70 to 20/160. This has already been told to us by ETDRS. So what is moderate NPDR with DME? You are seeing the moderate disease and you are seeing central involved maculopathy. They found that there was a 2-step improvement in patients who were getting diabetic retinopathy and the quality of life improved. It also improved the probability of a new proliferative event is less when you give injections of monthly dosage. And that was studied by Protocol W, where they decided to look for aflibercept in PDR. And they found that there was an less incidence of DME and less need for vitrectomy. So the disease rapidly involutes with the anti-VEGF, but the compliance is very difficult. So basic thing is identify the STDR and refer for surgery before severe visual loss occurs. You don't refer after visual loss occurs. And remember that younger patients with PDR are at a higher risk of visual loss. So take-home messages, give recommended ophthalmic care, which should reduce the prevalence by 52% of blindness. And direct cost of the care is lesser than the loss of productivity and cost of disability facilities. Thank you.
Thank you, madam, for that wonderful